And my name is Jayne Quinn. I'm the pain resource nurse here at MUSC, and I feel privileged to work with a group of talented and dedicated medical professionals who really understand what patients are going through who have pancreatitis, especially chronic pancreatitis. And Dr. Bellier talked a lot about some of the coping mechanisms, the non-drug coping mechanisms, but I'm going to try to let you know about what's important to understand about pain and chronic pain and how you actually do have some control over that, believe it or not. So in the medical world, we say pain is what the patient says it is, when it is, where it is. The patient's self-report, the patient's communication about how much pain they're in, that's the gold standard. So it's not the nurse in the emergency room who says, oh, no, don't worry, I don't care that you're crawling on the floor and that you're like writhing in pain. I'm going to give you a 3 and now you can go. So that's not really what it is. The reality is the patient is what you say, the pain is what a patient says it is, when it is, where it is. So always know it's different for each patient, and we don't want to get stuck on a number. We want to look at how does that pain affect you, how does it work on your quality of life, on your functioning, but just know that the intensity of the pain, that 0 to 10 scale that we use in our healthcare system, is a tool. It's just a number. It's just like your blood pressure is a number, just like your pulse is a number. We don't evaluate patients' cardiovascular status based on their heart rate alone. So it's just one piece of the puzzle and helps us to identify in a quantifiable way, is this intervention that we're doing having any effect in decreasing that pain level that you have? Some people, that trust question that Dr. Adams asked, some people who have chronic pain live their lives unfortunately treated in a way where nobody believes them and it's all in your head, as Dr. Bellier said. We're going to look at an 8-minute video on chronic pain. This 8-minute video is a TED Talk. Dr. Elliot Crane is a pediatric anesthesiologist in Stanford, and the video is geared towards medical personnel, but again, you'll be able to appreciate it and understand it. And the point of it all is you can Google this, it's on YouTube, and you can show it to friends, family, maybe people who aren't so friendly to you, so that they can understand what chronic pain really means to you and to your body.
I'm a pediatrician and an anesthesiologist, so I put children to sleep for a living. And I'm an academic, so I put audiences to sleep for free. But what I actually mostly do is I manage the pain management service at the Packard Children's Hospital up at Stanford in Palo Alto. And it's from the experience of about 20 or 25 years of doing that I want to bring to you the message this morning that pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months and oftentimes for years. And when that happens, it is its own disease. And before I tell you about how it is that we think that happens and what we can do about it, I want to show you how it feels for my patients. So imagine, if you will, that I'm stroking your arm with this feather, as I'm stroking my arm right now. Now I want you to imagine that I'm stroking it with this. Please keep your seat. A very different feeling. Now, what does it have to do with chronic pain? Imagine, if you will, these two ideas together. Imagine what your life would be like if I were to stroke it with this feather, but your brain was telling you that this is what you are feeling. And that is the experience of my patients with chronic pain. In fact, imagine something even worse. Imagine I were to stroke your child's arm with this feather, and their brain were telling them that they were feeling this hot torch. That was the experience of my patient Chandler, whom you see in the photograph. As you can see, she's a beautiful young woman. She was 16 years old last year when I met her, and she aspired to be a professional dancer. And during the course of one of her dance rehearsals, she fell on her outstretched arm and sprained her wrist. Now, you would probably imagine, as she did, that a wrist sprain is a trivial event in a person's life. Wrap it in an ace bandage, take some ibuprofen for a week or two, and that's the end of the story. But in Chandler's case, that was the beginning of the story. This is what her arm looked like when she came to my clinic about 3 months after her sprain. You can see that the arm is discolored, purplish in color. It was cadaverically cold to the touch. The muscles were frozen, paralyzed. Dystonic is how we refer to that. The pain had spread from her wrist to her hands, to her fingertips, from her wrist up to her elbow, almost all the way to her shoulder. But the worst part was not the spontaneous pain that was there 24 hours a day. The worst part was that she had allodynia, the medical term for the phenomenon that I just illustrated with the feather and with the torch. The lightest touch of her arm, the touch of a hand, the touch even of a sleeve of a garment as she put it on, caused excruciating, burning pain. How can the nervous system get this so wrong? How can the nervous system misinterpret an innocent sensation like the touch of a hand and turn it into the malevolent sensation of the touch of the flame? Well, you probably imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling, and from the junction box to the light bulb. And when you turn the switch on, the light goes on, and when you turn the switch off, the light goes off. So people imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm, that of course we call nerves, transmit the information up to the junction box in the spinal cord, where new wires, new nerves, take the information up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that that junction box in the spinal cord is just simply where one nerve communicates with the next nerve by releasing these little brown packets of chemical information called neurotransmitters in a linear one-on-one fashion, in fact, what happens is the neurotransmitters spill out in 3 dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structural elements of the spinal cord that did nothing more than hold all the important things together like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated, their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves, and they start releasing their neurotransmitters. And those neurotransmitters spill out and activate adjacent glial cells, and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your wall so that the next time you turned on the light switch, the toilet flushed 3 doors down, or your dishwasher went on, or your computer monitor turned off. That's crazy, but that's in fact what happens with chronic pain, and that's why pain becomes its own disease. The nervous system has plasticity. It changes and it morphs in response to stimuli. Well, what do we do about that? What can we do in a case like Chandler's? We treat these patients in a rather crude fashion at this point in time. We treat them with symptom-modifying drugs, painkillers, which are frankly not very effective for this kind of pain. We take nerves that are noisy and active, that should be quiet, and we put them to sleep with local anesthetics. And most importantly, what we do is we use a rigorous and often uncomfortable process of physical therapy and occupational therapy to retrain the nerves in the nervous system to respond normally to the activities and sensory experiences that are part of everyday life. And we support all of that with an intensive psychotherapy program to address the despondency, despair, and depression that always accompanies severe chronic pain. It's successful, as you can see from this video of Chandler, who 2 months after we first met her is now doing a backflip. And I had lunch with her yesterday because she's a college student studying dance at Long Beach here. And she's doing absolutely fantastic. But the future is actually even brighter. The future holds the promise that new drugs will be developed that are not symptom-modifying drugs that simply mask the problem, as we have now, but that will be disease-modifying drugs that will actually go right to the root of the problem and attack those glial cells or those pernicious proteins that the glial cells elaborate that spill over and cause this central nervous system wind-up or plasticity that so is capable of distorting and amplifying the sensory experience that we call pain. So that I have hope that in the future, the prophetic words of George Carlin will be realized, who said, "My philosophy, no pain, no pain." Thank you very much.
The concept to understand about that is it's not black and white. There's no one silver bullet. There are things we have control over, and then there are things we can't control. But knowledge is power. And I'm not saying that the pain is in your head. But what I am saying is that your brain has the power to help control the pain. And part of that is some of the tools that Dr. Ballier mentioned. So the first step is understanding how pain works in your body. And then you'll understand why we prescribe different types of medications, sometimes opioids, narcotics, sometimes adjuvant medicines. Those are additional medicines like antidepressants or anti-epileptic drugs that we don't use for depression or epilepsy, but we use because they calm the nerves. They decrease that pain sensation. There's all kinds of things that can help in controlling that pain. And the mind-body techniques, the non-drug techniques, are very important as well. So multimodal analgesia and the non-pharmacologic approaches to pain management, those are the two handouts that I gave you to start with. So what does multimodal analgesia mean? It's a lot of words to say. It's basically a combination of pain medicines or other medicines that have different ways of acting on decreasing that pain sensation or the perception of pain in your body. The concept is that if you add a few together, you can use lower doses of each individual medication, and therefore you're going to have less side effects because you're using them at lower doses. And when you combine this with the non-drug therapies and the education, then you build what I call a toolbox. You want to have a toolbox of all different types of tools to help manage and cope with pain. And the most important thing is you don't want these tools to be rusty and damaged, but you want to practice and use them and hone them, especially the non-drug tools, the mind-body techniques, whether it's yoga or meditation or guided imagery, walking on the beach when or going out into the mountains, whatever it is, your grandchild, your husband, your wife, those things that make you feel good about life, those are all tools. One thing that I think people can relate to or understand is for women who have delivered babies and gone through that those breathing exercises, Lamaze or whatever however old you are, however you remember them. Those exercises don't take away the pain of childbirth, but they help to focus. They help to diminish that perception of pain so that you can cope with that period of that acute pain, and then once the baby is delivered, then hopefully you forget about it, because if you didn't, then we'd only have families with one child and that would be it, or maybe not at all. So it's really important to practice these tools, and what I say to patients is pick one that you can relate to. Some people look at this stuff and they say it's hooey, it's voodoo. Pick something that makes sense to you. I bet you have something in your life that you already do. Some people say the Serenity Prayer. Some people count to 10. You already have those tools in your toolbox, you just don't know it. So one of the things we try to do in the pain management education is find out what works for you as an individual patient and label it as one of those tools that you're going to use in coping. Because it's very, very important to get back control over the things you can control in your life, because there are plenty of things that you can't control. But acknowledging what's going on in your body, learning how to know what the triggers are, that if there are any, that might trigger your pain episodes, and avoid those triggers. Having a plan in place, plan A and plan B. Plan A is just going about your daily life and you're not having any pain that's interfering with your function. But plan B is what happens when I get an acute episode of pain? What am I going to do? So there are certain things that you need to have in your back pocket to be able to do as soon as that pain starts. One part, multimodal analgesia, the handout has a picture on the back, and it basically just shows all the different types of things that we try to use in pain management and how it affects the different areas of that pathway of pain that Dr. Crane described. So in the peripheral area, you know, like on your skin, we're talking about non-steroidal anti-inflammatory drugs, local anesthetics like lidocaine, cold or heat. How many people, you know, when you smack your hand and you put an ice pack on, it takes that pain away. That's a local peripheral application of pain management. Another concept, if you hit your hand and you rub it, what you're doing is you're sending a million different sensations that are not painful to kind of drown out that pain signal. So there's a lot of things that can be done when the pain is localized, which is not true about pancreatitis pain. That pain is not localized. That's deep inside. So what other where else do we try to impact that pain pathway? Well, in the spinal cord itself, the opioid medications or narcotics that people talk about, or some types of procedures like epidurals or intrathecal injections sometimes can be helpful for patients with chronic pain. In the brain itself, besides opioids, opioids are everywhere in the ascending and descending pathway, in the spinal cord, in the brain. But also in the brain, look at this, education, imagery, and relaxation. And this is where I want to make sure you understand these are the things that you have control over. These are the areas that you want to concentrate on to build those tools for your toolbox. And the other medicines that we use, or treatments that we use in the ascending and descending pathway of the pain are things like antidepressants, like Elavil, you've heard of, or Pamelor, anti-epileptics, things like Neurontin, which is gabapentin, or Lyrica, which is pregabalin, and then some other medications, clonidine, and a treatment called TENS, transcutaneous electrical nerve stimulation. Those types of treatments work on pain in the ascending and descending pathway. So they work on how we perceive pain. This is just an image to show you that it's not just one silver bullet. It takes all these different treatments and tools. There are the non-pharmacologic approaches, again, Dr. Ballier highlighted them, but pretty much what you want to use these for is because they can help control those physiological and the psychological responses that can amplify that pain signal. The whole concept that we want to do is we want to dampen the pain signal. We want anything that's going to make it a little bit less. So if one tool can dampen it a little bit, and a medication can help dampen that pain signal in another way, and talking to your friend on the phone can help dampen that signal in another way, then in combination, it all helps much more than if you just try one thing. And also we want to look at changing the perception of pain and changing your perception on whether you can control it or not. Because if you feel like you can't control it, that's going to be much more difficult to deal with than if you feel like you have some sense of control. And these types of therapies, the non-pharmacologic, the non-drug therapies, don't take the place of the traditional therapies, but they enhance those therapies. Any questions? No pain, no pain. Okay, thank you.